and in the streets, and especially children and old people are very much affected by them. So that's why I pose this question, so that we can know how we must improve in our infrastructure in this country to really make sure that our communities are safe. And then also, what is the survival time of coronaviruses in water and wastewater? What have been the notable gains of undertaking skills transfer and capacity building of universities and other stakeholders? And how will the SAMRC expand its network in this regard? Regarding the Sisonke implementation study, Professor Gray, what were the key lessons for rolling out vaccines for healthcare workers and the nation? Please elaborate on the adverse effects that were found or reported in the study, taking into account the vaccines that are on offer in South Africa. Is there empirical evidence of other more severe adverse effects from vaccinations? Then how long did it take the SAMRC to evaluate the impact of variants of concern on vaccine effectiveness? In hindsight, what could have been done differently, if anything? Last question on that one. What can be said about the safety of vaccines for different categories in this regard? What are the best ways to ensure safety in the field? Then my general comments on this one, Professor Gray. Research indicates that immunization or vaccination is really the most effective preventative measure against serious diseases. There are media reports that indicate that people who have been fully vaccinated could need COVID-19 booster shots within a year to 18 months. The research is ongoing, however. It is very important that we know what to expect. Can the SAMRC briefly elaborate whether the speculations are correct or not regarding the potential need for booster shots? And I've heard that the Sisonke trial on booster shots will start from tomorrow. And what will be the time frame before it reaches the rest of the population? I thank you, Professor Gray.
Start and we'll ask my team to also chip in and answer the question. So for member Christians around the wastewater surveillance. So first of all, when we look at wastewater for surveillance to pick up COVID, we're looking at degraded virus, not viable virus. But this degraded virus, which is excreted in your stools, is not viable, so it's not going to transmit COVID to anyone, but will help us detect in a very early fashion any future outbreaks. So wastewater surveillance is important for that. I'm going to also, we'll go into it a bit more and when we ask our other teams to talk about it. But I agree that sewage in our country is in despair. And we never realized how bad the sewage was in our country until we started to do this work. And Professor Angela Matee will just highlight some of the stuff. And one of the first things we need to do at a municipal level is to make sure that we can sort out our sewage systems, because I think they're in disarray, and they can cause a lot of other ill health, like E. coli in our water, and which can cause diarrhea and other things. We'll ask Angela just to talk a little bit later about some of the issues that we face, but we do want to flag wastewater and sewage, because it is a huge problem in our country, and we agree with you. It poses a lot of danger, not only in the Northern Cape, but in all parts of our country, and Angela will talk a little bit more about that. Today, at the moment, infections are very low, and you're correct. These are the people that are coming forward for testing. Obviously, testing always underreports the true amount of cases in the country, but we are reassured by looking at our death data. So we track we track excess deaths in the country, and the excess deaths correlates with the epidemic, and we also correlate it with the hospital admissions. And so we can say that the excess deaths together with hospital admissions are showing a decline in the number of COVID infections in our country, cases will always be, the tests that we know will always be an underrepresentation, because not everybody who is symptomatic and not everybody who is sick will go for a COVID test. So they always are underreported, but we can see by other levels like deaths and hospitalizations that the rates are low at the moment. And what can we do to keep them like that? We can keep them like that by, number one, vaccinating. We have to increase our coverage of vaccination in this country. And all these interventions are very important. Without good vaccine coverage, it's very hard for us to control future surges. We also need to continue to wash our hands, wear our masks, make sure there's ventilation, and try and make sure we don't that we respect the space, the hand washing, the mask wearing, and the working in well ventilated areas and moving around in well ventilated places. So that's very important for us. In terms of the new drug, the next phase of managing a pandemic is to get a medication that can help treat COVID. So vaccines will help prevent COVID and will help downgrade COVID infection from severe to less severe. But what we do need as well is interventions for therapeutics. And this antiviral is a very important move forward. It doesn't replace vaccines, because vaccines are preventative, but this having an antiviral on board means that when people go to the hospital and are very sick, they can take this antiviral. We will have to rely on the company and maybe lobby the company to work with SAHPRA to get this antiviral registered in the country, but it can never replace vaccines. It's just another tool that we will have in our kit to try and control and manage COVID, particularly for people who are in hospital and who are very sick. Hopefully this antiviral will help this. In terms of monitoring trends abroad, it's very important for us to monitor trends abroad, because as we open up our borders and as people move around the countries, we know that in winter in the Northern Hemisphere, COVID outbreaks happen, and they already are happening in Europe. And we need to monitor what variants are happening in those countries. And we need to see how that impacts, because obviously people are moving across the globe. So what we are doing in that respect is that we are monitoring wastewater at the airports, particularly the international section, to see which of the travelers that are coming into our country have evidence of COVID in their stools, and whether there's any new variants that are present in the stool. So those are very important for us. Important for us also to continue to do genome sequencing of any outbreaks in South Africa. If we look at last year, we started to have a surge in late November, early December, and this was propagated a lot by movement of young people. Young people had been restrained throughout the year, and there was a lot of mixing of people who were in matric, who then obviously brought the COVID infections into the household. So we have to wait. We had a very torrid Delta surge, and the Delta surge that infected a lot of people, together with the vaccines, may have an impact on the severity and the duration and the timing of the next wave. But what we have to do in this stage is, in anticipation of the next wave, is we have to make sure we increase our vaccine coverage. And we'll come back to some of those later when I ask some of the other members and my other committee teams to talk. Member Ndegeni asked about the funding and whether we have enough money for future research and how much is needed. We will need a lot more money for research. We cobbled away a budget, and we were fortunate enough to get more money from Treasury and from the Department of Science and Innovation, and to work with TIA. But if we want to be involved in vaccine development, like the mRNA hub that we are hosting here in South Africa, we are going to have to fund a lot of the innovation. We also need to fund local drug development as well as diagnostic development. So although we're able to leverage our money, South Africa is very good with leveraging our money, and our money leveraging has helped us work with other collaborators. So we've had a lot of multilateral collaborators. The first one was with the NIH CoVPN that helped us do some of the COVID vaccine trials in South Africa, that helped us establish that the J&J vaccine worked. So that was a collaboration with the NIH CoVPN, Operation Warp Speed and BARDA. We've also worked with the Gates Foundation, who've helped co-fund the Sasonke study together with the Elmer Foundation and the Dell Foundation. We work very closely with BRICS we worked with them on the diagnostics, and we'll go further into that, but we have a very good relationship with BRICS. And then with the Africa CDC and the AU, we've worked with diagnostics and supported them in surveillance as well. So strategic partnerships are important. We are indebted to China for supporting the diagnostic development, and also to supporting access to PPE. We're working with Nomalux and Sinovac from China in looking at the coronavac vaccine in children. So there is a study ongoing in South Africa that looks at the coronavac vaccine. This is a two-dose vaccine. It's an inactivated vaccine. It's been given to about 30 million children worldwide. And we're busy evaluating that in children from as young as 6 months to as old as 12. And that data is, we've enrolled around 2,000 children in the country, and together with Nomalux, and they will be showing the data to the VMAC as well. Why do parents bring their children to be vaccinated? I think that for the study, a lot of the people that brought their children forward had already been involved in COVID vaccine research and saw the value of COVID vaccine research. And so that's why a lot of the children have come forward to be involved in this research. In terms of the vaccine rollout, as we know that the single dose Pfizer is given to children over 12. That's been going very well. The reason to vaccinate children is to try and keep the academic school year open. 40% of school days were lost, and by vaccinating children, we can prevent severe COVID in children, as well as keeping the school open, and also as well as protecting teachers and households. We know we live in intergenerational households, and so if we can prevent a COVID infection coming into the household through a child, we can be maybe able to prevent COVID in elderly people who are in the program. In terms of consenting, children over 12 can consent to interventions, and so but we have seen a lot of collaboration between parents and children, and it's nice to see parents bringing their children through to be vaccinated, but the child will provide consent for that. And we'll ask for some of the other EMC members to talk a little bit more about that. In terms of member Gillian, about the vaccine going down in age. So in order to start to control COVID transmission and COVID infection in the country, we need to increase coverage, and we need to make sure that people over 60, over 50, over 40, over 30, and anyone under 18 between 12 and 18 gets vaccinated, because the only way we can impact on the next wave is to make sure we increase the coverage of our vaccine. We have to try and understand vaccine hesitancy a little bit more. A lot of people are undecided. They're not anti-vaxxers, but they're scared of the side effects, and they don't know anyone in their community that has had vaccines. And so we need to spend a little bit more time, particularly in rural areas and in other age groups, to try and understand what makes people scared to get the vaccine. And we've seen that a lot of people, once they have the knowledge of the vaccine, they're very happy to take it. And so I think we need to spend more time. In the beginning of the vaccine rollout, there was always a problem with supply, and we had to be very careful how we created demand when there was no supply. We didn't want vaccine sites to be mobbed, and so we had to be very careful how we rolled out the vaccine. But now that the supply has been secured, we need to do lots of innovation, and we've been doing some innovation in SASA grant queues, in these pop-out things during the IEC. We've seen that happen. We also are working this new program with Vuma. You can get 100 Rand if you get a vaccine this month. So that's also important, and it's just to continue to innovate in terms of addressing people's concerns around the vaccine. In terms of the Sisonke implementation study, this implementation study did establish the effectiveness of the COVID-19 J&J vaccine in healthcare workers against death and hospitalization, and we showed that in the beta wave and in the delta wave, this vaccine has shown protection. Because these healthcare workers got the vaccine very early on, and because data has emerged showing that a second dose of the J&J increases vaccine effectiveness, we're going to give the healthcare workers a booster, because we know that it's safe, we know that it's immunogenic, and we know that it increases vaccine efficacy. So we want to vaccinate these healthcare workers ahead of a possible next wave that we might anticipate in the December months. I think Anjali will talk more about the collaboration between the MRC and the wastewater and the Water Commission. Angie, you'll talk about the Water Research Commission and our collaboration with them. In terms of funding research and innovation, we are evaluating COVID-19 in children. Children who are immunosuppressed and who may have TB or maybe HIV infected or have other illnesses are vulnerable to adverse events. Some children who get COVID get a post-inflammatory syndrome, and that is one of another reasons why we try and want to vaccinate children, because we want to prevent any severe outcomes in children who may get COVID. Michelle will talk about the Solidarity trial in the Crown, and then Angie will talk about the Water Research Committee and other questions around the wastewater, and the issues around the difficulties in sewage research. In terms of the Sisonke, the lessons learned, what are the lessons learned? We've seen, I think we learned about, what are the lessons learned? The lessons learned was how to make sure the electronic vaccine data system worked. And so we were able to test the electronic vaccine data system and develop a electronic record, which gives us access to a vaccine certificate that you can use all over the country. The Sisonke trial, because we were able to track the healthcare workers, we've got very good data on hospitalization, on the impact of comorbidities, the impact of age, impact of HIV on vaccine effectiveness, and this will help us develop strategies to enhance the durability of vaccines. The important thing of the Sisonke program also is our ability to evaluate whether there is waning efficacy and to time the boost. By giving the healthcare workers the boost now, we'll be able to assess for future people who got the single dose J&J, what is the best time to get the boost, and it'll help us to evaluate how a boosting regimen improves effectiveness. The important thing also around the Sisonke taught us about the impact the variants of concern on vaccine effectiveness, so that was very important, and also taught us about the side effects of the vaccine. And we were very happy and reassured to see that the vaccine side effects were not different to what has been reported all over the world, and that when we looked at the vascular disorders and the nervous system disorders and the immune system disorders, the amount of side effects by organ class were not different to what we saw at a global level. There are some rare events, there are some rare side effects that occur. For every 1 million vaccinations you get, you may get 4 rare side effects with Guillain-Barré syndrome, and also that usually occurs mostly in men. And but if recognized, it's easily to treat. In women, we see between 2 and 4 per 1 million vaccinations. We may see this rare thrombotic thrombocytopenia event, and if identified, also is easy to treat. And so we've been able to develop capacity to develop to treat the side effects, and also to make sure that the number of side effects in South Africa is not more than where we see in any other parts of the world. So we don't have any safety signals, and so giving the Sisonke boost will help us understand what the safety side effects are of getting 2 boosts, and will add the global knowledge on this. We definitely are happy that we have a good handle on the side effects that we see in South Africa, and that they're no different to other parts of the world. What we have also looked at, because sometimes it's very hard to know whether the side effect is increased as compared to background side effects. And so we've been looking at data to see what is the expected number of thrombotic events we should see, and getting vaccinated, this increased the number of side effects. And the only area we saw that there was an increase was in the Guillain-Barré syndrome, which we know about at a global level, and also in the thrombotic thrombocytopenia, which has been well described at a global level. In terms of the COVID infections, breakthrough infections amongst healthcare workers, most of them were mild. So there were around 22,000 breakthrough infections, and of those, most of them were mild. And we definitely saw an impact and reduction in hospitalization and death post-vaccination. The value of Sisonke is that we will be able to track these healthcare workers over time to see, so of those healthcare workers who decide not to be boosted, we'll be able to compare boosted healthcare workers to non-boosted healthcare workers. And if any other vaccine becomes available to these healthcare workers, we'll be able to evaluate the impact of the new vaccines boosted on as compared to the J&J boost. I'm going to just quickly ask Angie to talk a little bit more about the wastewater surveillance, and then to ask Mongezi and Michelle just to add anything about some of the therapeutic stuff that we've been doing. Angie?
Yes, just to concur with Prof. Gray, that the wastewater, the SARS-CoV-2 virus doesn't survive very long in wastewater at all, much shorter survival periods than polio virus, for example. So, and we're just picking up fragments, so that's not a major public health concern for us. More importantly is the state of dysfunction of our wastewater treatment plants from a broader public health perspective. We have been truly shocked at what we've seen, how dysfunctional, how insecure the wastewater treatment plants are, to the extent that in some instances we've declined to include certain wastewater treatment plants in our program because we think it is just far too dysfunctional to be useful for our program, and moreover, the concerns for the public health of the affected communities from other ill health conditions is a major concern. So in that regard, we have received some funding through a partnership with colleagues in the United Kingdom and in Nigeria, and we hope to intensify our research on non-sewered communities in the coming months. On the partnership with the Water Research Commission, the Water Research Commission funds the NICD to do the wastewater surveillance for them. And so we do have a partnership with the NICD. We have regular meetings. There are links between our two dashboards, and we're having discussions about joint projects, for example, on variants of concern. We also compare our methods, and we belong to the same wastewater surveillance networks in the country. There's definitely collaboration going on there. And then on capacity development, some of our partners are the University of Fort Hare, University of Venda, Sefako Makgato University. And in that regard, we've been able to provide equipment, consumables training, laboratory training, as well as field training. We are just about, we hope in December now to start a program of data analysis support as well as writing training. So we definitely has been the case that where there was no capacity before, the MRC has been able to facilitate capacity in poorly resourced institutions going forward. And there is the possibility of a future collaboration on non-SARS-CoV-2 research, like I mentioned earlier, on chronic diseases, tracking HIV/AIDS in communities, etc. I think I've covered all the questions that were asked to me, but obviously happy to answer any others. Dr. Mongezi Mdluli, who leads the program on wastewater at the MRC, may also have additional comments to make.
Thanks, Angie. I think you covered most of the stuff, or all of them, that were asked. Thank you very much.
Chair, we've just got some discussion about the therapeutics that was asked, at the Solidarity and the Crown. So we're just going to answer that question.
Thanks. It's Michelle Mulder here. Sorry, I didn't introduce myself earlier. So we've been co-supporting the Solidarity trial and the Crown coronation. The Solidarity trial is being undertaken by, or was undertaken by the Wits Reproductive Health Institute, Wits RHI. They were significant participators in this global trial. Unfortunately, the results indicated that the 4 drugs that were used had no direct effect on hospitalization, initiation of ventilation, or preventing deaths. So those results came out some time ago. There was a plan for the same sites to be involved in the Solidarity Plus trial, but when they looked at the different drugs that were planned to be used in that, they were not feasible for use in South Africa due to contraindications with existing standard of care and various other reasons. So the Wits RHI are not participating further in the Solidarity trial as far as I'm aware. The Crown coronation study started off as a study looking at hydroxychloroquine, but it was realized quite early on that this was not really going to have an effect. It was for prevention in healthcare workers. So they've amended the protocol, and they are now looking at the MMR vaccine as a potential preventative. And of course, this has been done in the context of new vaccines specifically for COVID coming on board and showing efficacy. So they've had to adapt, and they've expanded this beyond healthcare workers. So as of March this year, there were 11 sites recruiting, just around 1,200 participants in South Africa who are participating in that study. Thank you.
So thank you, Chair. So we're happy to ask answer any more questions. But I think we lost you.
Thank you, Dr. Gray. Let me take this opportunity to be a temporal chairperson because we've got a problem of network. I'm sorry about that. Members, any person want to have a second bite? Is anybody, Michelle, Ms. Marcel, I don't see anything. If you will have any, will see any hand, can you please help me?
Thank you, Ms. Mongeni. I do have 2 questions from Ms. Lahihi, if you permit me to ask those questions.
Yes, dear.
I'll go ahead now.
Yes.
The question was, what were the key lessons for roll-out vaccine for healthcare workers and for the nation? And the second one, what are the difficulties in conducting sewage research for virus spread monitoring? That was the two questions.
Okay,
Thank
thank you,
you.
Michelle. Thank you, Doctor. Can you please help us with the answers?
Sure. Thank you, Chair. The key lessons for the rollout, we learned about, first of all, how to scale up. So we learned about vaccine data system and the importance of electronic records, which are critical for national health insurance and a future health system. So I think that was the first important thing. The second thing, it taught us how to scale up. We had never done an adult vaccination program, and the Sisonke period taught us how to go to scale. It taught us about how to manage the whole vaccine process, the registration, what to do, and how to move people through the various stations, and to be able to do 100 at any one site, to do 100 vaccinations an hour. And so this preliminary period taught us how to take the vaccine to scale, and just to remind you that the country now has the capacity to do between 250,000 to 300,000 vaccines a day. So every 2 days, we have about 400,000 vaccines happening, and the vaccine rollout has gone from strength to strength. And when we were doing our vaccine rollout, we had very little vaccine supply, and we could only do 20,000 vaccines a day. So imagine that we've gone from 20,000 vaccines to 200,000 vaccines a day, and that is phenomenal. So that was the lessons to learn how to scale up. It also taught us about safety and how to manage safety, and so we were able to we established a safety desk, and we were able to support once the national rollout transitioned, we were able to support the National Department of Health in how we manage the safety events in our study. And so that was very important. And we were also able to work with the Department of Health in terms of managing other safety events, but because everybody knew Sisonke, whether you got a Pfizer or a J&J, people would contact our safety desk, and we were able to support the National Department of Health in that. Other key lessons, is about training. So we were able to train vaccinators how to administer the vaccine. We were also able to establish the cold chain storage. So before we were able, the whole vaccine program needed transportation, needed depots to store the vaccine, and needed a system to move the vaccine through the supply chain management. And this initial process taught us how to manage vaccine deployment and how to manage the cold chain. So lots of lessons that were learned in that. And just to say that the vaccine rollout now is incredibly sophisticated, and the movement of vaccines all over the country is well orchestrated. You put your request in for vaccines on a Wednesday, and that is delivered to your institution. The EVDS is critical for us to manage stock, and to manage numbers, and to manage side effects, and to also evaluate from a population level how the vaccines are doing. So I think there's a lot of things that we had to that we learned in terms of the Sisonke rollout. And again, Sisonke will help the national rollout again, because we're now entering into how do we boost. And so we will be able to work with the Department of Health and explain to them and support them in the boosting of other people who were in the national rollout. In terms of difficulties in the wastewater surveillance, so wastewater surveillance is important not only for SARS-CoV-2 surveillance, it's important for surveillance for polio, for measles, and for other infectious diseases. And these will also alert us to, if we start to do surveillance in measles and polio and other infectious diseases, it can alert us to vaccine breakage. We know already that last year a lot of children didn't get their immunizations because of the parents were scared to go to the health system. So by doing wastewater surveillance for polio, measles, we are able to then alert the authorities that there's a break in vaccination coverage in certain infectious diseases. So I think it's going to be very critical for us. It also tells us about what else is happening in terms of people who are taking antihypertensives, people who are on ARVs, and that helps us understand how people are managing their chronic diseases going forward. But I'll ask Angela to also expand on that. So wastewater is also important for drugs. So if we are worried about illicit drug use, by looking at wastewater, we can pick up pockets in communities where there is a use of illicit drugs, and that will help us manage drug abuse in our country. Angela, I don't know if you want to just say anything more about that.
Just to add, the promise of wastewater surveillance to help produce a new or amend or add to the public health model that we have, because like Professor Gray says, there's so much information. It's really a treasure trove of information in wastewater that we haven't really capitalized on up to now. In terms of the challenges, it is really just the complexity of it, the logistics of getting information, all the small minor things that can go wrong in getting the samples to the laboratories, getting the consumables that we need. But we have a really passionate, energetic team that is determined to make a difference, to do their bit to help prevent disease and to save lives. So all the challenges over the past year and a half, we've been able to manage all of them. Funding and resources is always a challenge. We think we have brilliant ideas in terms of extending the platform that the SAMRC has created, and additional funding would always be very well received. Thanks, Prof.
Oh, sorry, I forgot what I'm sharing now. Thank you, Dr. Crane, about the information. Myself, anybody or any member have a question?
Ndogeni, I think we've come to the end of our question and answer session. Thank you.
Oh, thank you. Thank you, Dr. Crane, about the presentation and the information. We appreciated that. But I can release you so that we can continue with our meeting. Thank you very much, Dr. Craig and your team.
Thank you very much, and we're very happy to have presented to you, and good luck on your future deliberations, and happy to come back again. Thank you very much.
You will. Thank you.
Thank you.
All right. Mr.
Ms. Ndogeni, I will share the draft fourth term program for members to peruse, and then we can adopt that program.
Okay. We are in is it a fourth term program or?
Yes, Ms. Ndogeni, it's the fourth term program.
Oh, okay. Members, anybody can adopt? Hello?
Chairperson, are you able to see the screen? Are you able to see the program?
Yes.
Do you want me to read through the program, or is it are members able to just look from the program and then we can decide, then we can move on?
No, we must move on because everybody have the program.
I'll wait on you, Chairperson.
Members, can you please help me? Anybody can move for the adoption of the program.
Christians, move for the adoption.
Oh, thank you, Member Christian. The second one? Hello?
Let me second, Chairperson.
Oh, thank you, Honorable Baha. Michelle, where we are now?
Chairperson, the adoption of the program is the final agenda item. If you are ready, we can close the meeting.
Oh, thank you very much. Members, we come to the end of our meeting now. Thank you very much for your availability. I appreciate that. Thanks a lot. The meeting has been adjourned.
Thank you. Bye, everyone.
Thank you,
you.
Chairperson.
Bye.
Thank you, members.
All right.
Recording stopped.